CSA Smartgroup. It's so happy to see you again. Today I'm here to talk about diagnosing of DVT and how we can manage at our GP surgery level. And there is a new protocol is going to come in Bradford soon. And this is regarding the rivaroxaban, how we can use it in our GP primary care. When we suspect DVT in one of our patients, it's always better to use we always use the Wells score, isn't it? Wells score involves the active cancer within 6 months of palliative, paralysis or recent plaster immobilization of the lower extremities, recently bedridden for 3 days or more, or any major surgery within 12 weeks, localized tenderness along the distribution of the DVT system, entire leg swollen, cough swelling more than 3 centimeters, pitting edema confined to the symptomatic leg and collateral superficial veins, and previously documented DVT, or alternative diagnosis is at least as likely as DVT. So we have to do this Wells score, and low score is 0 to 1 point and high score is 2 or more points. So when we do the Wells score, basically what we have to make sure to do like D-dimer, clotting screen, renal function, full blood count urinase, LFTs and CRP. And then we have to look for any contraindication for the primary care treatment with rivaroxaban, and they are like pregnancy or breastfeeding or postpartum, age less than 18 years. And the other contraindication is symptoms of PE if the blood pressure is more than 180 by 115, and if you anticipate compliance problem even with support in some patients, and severe renal impairment, CKD stage 5, eGFR less than 15 mils, and if the patient has already known to have liver failure, the risk of potential bleeding lesions like GI or GU or intracranial bleeding less than 4 weeks, congenital or acquired bleeding disorders or platelets less than 90, or if the patient is on contraindicated drugs, so they are not suitable for primary care treatment with rivaroxaban. So after doing this Wells score and the contraindication checking, and still if we suspect DVT, the best thing is to do, if the Wells score is 0 to 1, they falls into the low risk category. So do the D-dimer and see the D-dimer result, and if it's negative, stop the rivaroxaban. If it's positive, refer for the ultrasound scan. And if the ultrasound scan confirms DVT, then the patient needs to have rivaroxaban for minimum 3 months. If it doesn't show any DVT in the ultrasound, then the radiology department will repeat the ultrasound scan in a week's time. And the second patient group is like if the Wells score 2 or more, they fall into the high risk category. So even if the D-dimer is negative, anyway we will be sending these patients to the ultrasound check. And if there is no significant DVT in ultrasound, the radiology will check the D-dimer, and if it's positive, then they will ask the patient to come back again in a week's time for repeat ultrasound scan. But if it's negative, the radiology will discharge the patient back to our GP, and we have to stop the rivaroxaban. So that is the new thing, new protocol for managing DVT, suspected DVT in a primary care level. And with a positive result, how we have to treat the patient is like we start the rivaroxaban 15 milligram BD, and then if it's ultrasound showed any DVT, then we have to continue the rivaroxaban for 12 weeks in total, but the remaining is like rivaroxaban 20 milligram OD. So that is the main thing. The 15 milligram BD should not be repeated. That's the one point we have to note. So that's it. It's all about the new tablet rivaroxaban, otherwise called Xarelto, and make sure like how it can come in CSA scenario, and see how you can blend all those checklist, the Wells score and the contraindication to rivaroxaban in your history taking itself, and make it smooth and sleek. And don't forget to get the support system, the occupational impact, psychosocial impact, and everything, to give the holistic care. And see you soon in the next free videos, and share.
Thank you.